I request Dr. Anand Shigli sir to please welcome Dr. Dilip Damankar sir.
So, am I audible? Yes. Good morning, everyone. I thank Dr. Vijay More for those kind words. Well, it feels really awesome when someone introduces you who know him since last 15 years. We are working for so many conferences and so on. And first of all, I would like to thank Dr. Anand Shigli sir, Dr. Kamal Shigli ma'am, who has taken a lot of effort in arranging such a beautiful program. Yeah. So as Vijay sir said, can you switch off the lights, backlights, please? Yeah. So I have been associated with Prosthodontics Society since many years. Probably some 8 years back, we and Vijay Mabrurkar, Vijay More, we went to Bangalore and put a bid for starting this branch. So I am really proud to be associated, and so the total 6 degrees. Practically, it is like if you consider a clock, it is 12:01, making 5.5 degrees is pretty parallel. So this much parallelism we cannot get in the mouth. It is impossible even to get on the tabletop, you know. So Goodacre came with an article saying that anywhere between 10 to 22 degrees we get a clinically acceptable resistance and retention form. Well, there is a perfect relation between the height and the resistance and Biscott. This is a very, very important article. So Biscott studied relation of the height of the remaining height of the tooth after preparation to the retention and resistance form. On your right side, on my right side, the photograph shows that the tooth is tall. That means it will prevent the dislodgement of the crown. It will prevent the dislodgement of the crown. The occlusal portion will interfere with the dislodgement. Whereas if the preparation height is small, then it doesn't prevent the dislodgement. So we have to conserve tooth structure, make it as tall as possible, follow all the principles. So he further stated that for the zinc phosphate cement, the zinc phosphate cement is most amazing cement which has a very, very thin film thickness, but it doesn't last long because it is soluble in the oral cavity. So zinc phosphate I don't think many people use. So Viscott said a 4 millimeter height is essential for a long term success of a crown. But he further stated with after doing studies on resin composites, resin cement and glass ionomer, that resin cement has the maximum retention and resistance form at 4 millimeter, that is almost double of zinc phosphate. So whenever we are going to cement a crown, so if it is a metal ceramic or a metal crown, we have to go for GIC or resin modified GIC, and if the height of the tooth is small, then we can consider resin cement. So some auxiliary characters also have to be considered. For example, this type of tooth preparation we usually see in the lower second molars or upper second molars, where we have very limited access. So your burr cannot be held straight. You know, your diamond points cannot be held straight. So you end up in a taper. So in such cases, what we should do is we get the lower, gingival 1.5 millimeters at least, make it parallel, and rest of the thing let it be tapered, so it increases the resistance form exponentially. So the whole idea is to have maximum resistance form, in turn is going to give a retention form to the crown. So we know that the compressive stress shortens the body and the tensile stress elongates the body, and virtually all the materials which are used in dentistry have compressive and tensile load. So this is directly implicated on the resin, the cement which is used to cement a crown. So whenever we have an over tapered preparation, you can see there is 30 degree taper, So this cement is always under shear stress. So when the crown cement is under shear stress, the chances of dislodgement is too high. Whereas if I have a little parallel preparation like a 10 degrees or 15 degrees even, that cement is under always compression. So increasing the resistance form and eventually the longevity of a crown. So other things like structural durability, it should have an adequate thickness by giving a functional cusp bevel. Any textbook will explain all these things. Okay, this is very important slide. So how much to grind? You know, everybody, there is a lot of confusion how much to grind. It all depends on the type of material you are using. For metal, it is 1.5 on the functional, 1 on the functional. It's a famous, you know, everybody knows, even the undergraduates and third years. Metal ceramic, increase by 0.5 millimeters to accommodate that extra ceramic which is required. And for all ceramics, you require a lot of tooth preparation. That means I am talking about all ceramic which is layered. So we are going to go slightly in detail as when we advance in the presentation. So all ceramic do require a couple of millimeters of grinding, which is huge. The next principle is to have a planar reduction. The tooth is never straight, tooth is always in two angles. So you have to have gingival half preparation which is in a different angle and incisal half at a different angle like this. This gives us a lot of advantages. One, it conserves the tooth structure. Second, it makes the lower 1/3 parallel so that increase the resistance form. And third thing is it doesn't encroach the nerve. So we always have to have a planar reduction. Same thing has to be had for the posteriors, like you have to follow the occlusal anatomy. You should not make a tabletop preparation. If you do a tabletop preparation, the C factor increases and the chances of dislodgement of crown also increases. Marginal integrity is directly related to type of finish line which you are going to give. So this is a crown which usually we see in the bridge, which you usually see in the private practice, a hopeless saddle pontic or thick margins. Look at the cement. You know, we are talking about the cement in terms of 25 microns or 40 microns, and here it's like half a millimeter of cement. So obviously this bridge is going to dislodge. So we replace with some other bridge. So the last part of principles is the finish line configuration. So we have so many finish line configurations. So in my clinic, I use only two finish lines. That is, one is chamfer and other is deep chamfer. There is no other burr, like there is no flat and taper burr. There is no shoulder preparation in my clinic. So it's been 15 years. I'm using the same principle. So chamfer is most versatile finish line which will keep the cement under compression at the finish line or at the margin, whereas a deep chamfer, you take a round and tapered burr and probably like TR12 or TR13 go 50% into it. So that makes a good deep chamfer, and this finish line is enough for porcelain fused to zirconia, porcelain fused to metal, any crown which has porcelain. The shoulder, as I told you, I never use shoulder. This burr I don't have. This burr I use only to cut the metal crowns and failed crowns. Otherwise, this doesn't have any implication in my clinic. Radial shoulder is also a very good finish line, but we do not have good armamentarium to create this radial shoulder. So we don't have a burr which has a bevel here, a flat surface here. So obviously this is a very difficult finish line to create. So my practice, as I told you, I have a chamfer, that is SO21, and a long needle burr, this is TC21, and one finishing burr which is we call as yellow band finishing burr, which is used to finish the restorations. And the thing is, I never finish a restoration or a preparation which is going for a metal crown, which is going for a porcelain fused to metal crown, which is going for a zirconia crown. I finish with yellow band diamond burr only for laminate veneers, because laminate veneers purely is on bonding technology, which we are going to go in detail, and all other crowns, that is metal ceramic, are on cemented technology, that is water based cement. Path of insertion, obviously it has to be one. If you don't have a good path of insertion, just place one internal feature like a small box or a groove, that will take care. And how to survey the preparation undercuts. So many times we do the preparation, either we can make an impression, make a check cast and analyze, or in the mouth we have to eye, or we have to see the tooth preparation at a 12-inch distance and with one eye. We are not supposed to see with the both the eyes, because it creates a binocular vision and the undercuts are obscured. So this is how the tooth preparation is to be done. A depth orientation groove following the occlusal anatomy occlusal preparation. Then you give a functional cusp bevel. Functional cusp bevel is given for increasing the structural durability. I am going slightly in basics because I see so many students here. So sorry. So a functional cusp bevel and a depth orientation groove. A beginner has to always give a depth orientation groove and then go ahead with the preparation. And I want all the like final years and interns to do some 25 preparations on tabletop and 25 preparations on the typhodont, mounted on the mannequin. So you get an idea how to prepare the posteriors, how to prepare the lowers, how to prepare the anteriors. Good morning, Sulfagar sir. So this is a typical preparation for all ceramic and metal ceramic. Can you see this is like a deep chamfer or a shoulder with a radial shoulder finish line. This sacrifices so much of tooth structure. And this is a metal ceramic crown where porcelain is there you grind more, and where metal is there you grind less. On the palatal surface or on the lingual surface you always leave a metal collar. All the laboratories leave a metal collar. This metal collar reduces the tooth preparation, so increases the tooth structure preservation. Well, this is a video. I don't think there will be sound, but I would like to explain. So he is Gordon Christensen, who is trying to explain various types of tooth preparation, which we have to understand. So on the first photograph is for metal and all zirconia. The preparation guidelines for the metal and zirconia monolith, that is the full zirconia, are same. That is 1 millimeter all around. There is no rocket science in this, but when you do a porcelain fuse to metal preparation, you have to grind little more on the buccal and the proximal side, where your ceramic is going to come, and the lingual side same as the metal or all zirconia. And all ceramic crown is the one which requires an extensive preparation. So if you don't do a good clearance, I am going to tell you what exactly is happening with the zirconia crowns nowadays. So 25 दिन में पैसे double. So there is no shortcut in dentistry. In prosthodontics especially, you have to follow, you have to get the skill sets right. You have to get the you have to do a lot of effort to learn those fine procedures, and then only execute in the patient's mouth. So let me start with some of the case presentations. This is one case which I like to present. This is a porcelain fused to metal crown which we have planned. This patient reported to us with accretion. The teeth are at the level of almost gingiva, especially the posterior. This is how the occlusal photograph, right and left lateral. A thorough treatment plan is done. We have planned to increase the vertical dimension in this case. So a tooth preparation is done. So I always prefer to do all the tooth preparations in a single shot. In this case, we left only the third molars, which later were extracted. So if you see the preparation, they are pretty parallel, and all these crowns are individual crowns. They are never connected crowns. I connect the crowns only when the height of the tooth is too small. A face bow is done, and this is called an anterior deprogrammer, which deprograms the muscles before you go for a centric relation record. This is an alu wax, which we have taken a centric relation, and a temporization was done. And this temporization was done increasing the vertical height by a couple of millimeters. This is how the occlusion looks in the temporary crowns, and this is cemented. And after cementing the temporary crowns, we left it for a month to evaluate the temporomandibular joint. And we recalled, we made an impression, we did another face bow transfer, centric, we repeated everything. And this is how on a semi-adjustable articulator we mounted. These are the tooth preparations. If you analyze the preparation, all the entire finish line has to be seen They are not very parallel, but they are probably parallel in the tune of like 15 degrees, 7.5 degrees on either side. The total occlusal convergence, aim it at like 12, 15 degrees. Adjust the vertical dimension, a coping trial in the mouth, and this is very important. A coping trial, when the patient is on edge to edge, he should exhibit a posterior disclusion. A ceramic buildup is done, and you see the third molars are extracted except of one. And this is one thing which I would like to do whenever I do a full mouth rehabilitation. That is evaluation of all the final processes on the model, especially the contact points, the fit. I mean, sometimes you feel that the crown is rotating on the tooth preparation, you know. So that means the expansion factor or the thickness for the cement is really more. So after evaluation, we go and then we cement. So for full mouth, centric occlusion, and this is the posterior disclusion, and this is how he came, and this is how he went. Happy patient. But after introduction of metal-free ceramics, the entire scenario changed. You know, so metal ceramic we don't get so beautiful aesthetics, but metal-free we get a lot of good aesthetics. And metal-free is very technique sensitive as far as preparation guidelines are concerned, as far as material science is concerned, because there is so much of CAD involved. The machine calibration is so important. So we will just see. So we have two categories. One is zirconia, other is lithium disilicate. Zirconia we have monolith and layered, and lithium disilicate, that is an Emax crown, we have a pressable and CAD crown, you know, or a monolith Emax crown. So in my clinic, there is absolutely no layered zirconia. Layered zirconia is used only in the anteriors if the span of the bridge is little longer. Otherwise, my practice is with monolith and pressable Emax. So let us see the preparation guidelines for the monolith crown. It's just a millimeter all around with a chamfer margin. Treat the monolith zirconia crown just like a metal crown, you know, because zirconia in periodic table is a metal. But whenever you have a layered zirconia, you have to add up 0.5 millimeters to the buccal, to the lingual, to the occlusal preparation, so as to accommodate that extra ceramic buildup which your technician is going to do. Well, so let us see how the cementation of zirconia can go. A lot of confusion. Metal free, resin cement. Absolutely wrong. Metal free is not resin cement. Only lithium disilicate is resin cement. All zirconia are cemented with GIC or resin modified GIC. So the zirconia crown is always sandblasted. You know, zirconia crown is never etched. So we know the Emax crown is etched with hydrofluoric acid, which I am going to talk in detail about it. The zirconia crown is always sandblasted. As I told you, it's like a metal crown. You know, treat it like a metal crown. So when a metal crown comes from the laboratory, you see a rough surface in a fitting surface, right? So it is a sandblasted crown. So Gordon Christensen, I mean, one of the greatest in fixed partial denture. So he said that whenever the height of the tooth is small, like supposing 3 millimeters and less, you go for a resin cement. And when the tooth height is like 4 millimeters and above, I am talking about metal free, that is a zirconia crown, then you can just go ahead with the GIC or resin modified GIC. Because resin modified GIC and glass ionomer cement have a peculiar character of fluoride release, which is not there in the resin cement. So taller crowns which can retain on themselves, don't go for resin cement, and shorter crowns incorporate one internal feature like a proximal box or a groove to increase the resistance form, and then go ahead with the resin cement. So let's see one case. This is another full mouth zirconia case, you know. So he reported to us with extensive sensitivity. Ideally this is not for full mouth, but we tried to convince him by giving some desensitizing toothpaste and that and this, but it didn't materialize. He had a lot of pain even having a normal water. So we decided to go ahead with root canal for the anteriors and all posteriors without root canal or zirconia crowns, you know. A thorough treatment plan is done. This is the tooth preparation. So I want you to see the tooth preparation, you know, pretty parallel. So except for the lowers is very tough to get the parallelism because the neck of the tooth is very narrow. But otherwise, this is how the tooth preparation is done. and this is the occlusal view. All the posteriors are not root canal, and maybe canines are also not root canal. Only anteriors, which required a lot of preparation, we did the root canal. So our double cord technique is used for gingival displacement. I'm not going in detail about the gingival displacement. Well, I use UltraPack, which is my favorite, and gel cord, which is aluminum phosphate gel, or you can also use aluminum chloride gel, which gives an excellent hemostasis. So why double cord? Because whenever we have multiple teeth to be retracted or displaced, gingival displacement is called. So we use a double cord technique, and whenever we have a single crown, we use a single cord technique. So an impression is made, market is full of impression materials, addition silicone, the best. Then we have polyether, single crown, two crowns, we use a pentamix with a sectional tray, and all full mouth cases, obviously we are going to do a full mouth impression. This is a 3M material. Phasebow transfer, as I told you, anterior deprogrammer, centric relation record, and temporize. And after temporary, we leave it for a month to evaluate his temporomandibular joint. We increase the vertical by 1.5 millimeters or so. So phasebow mounted on the articulator, and this is how the clearance is established. So look at that. I have increased the clearance by 1 millimeter, So millimeter, 1.5 millimeters, maybe some areas 2 millimeters in the anterior zone. That is because I don't want my crowns to fracture. The biggest problem with the zirconia crown is that the crown fractures. Metal ceramic never fractures. Metal ceramic may chip off, but the zirconia crown fractures. And we went ahead with ceramic buildup. So all the posteriors are monolith. So only the anteriors are layered. So this is how the occlusion is established. Some 28 crowns. Now, as I told you, sit for 10 minutes, evaluate each and every contact point, the fit of the each and every crown, because whenever we are doing full mouth rehabilitation, a little bit of here and there, the other crown will not fit, while cementation. So what I observe in all such cases is the zirconia crown has some play. I think the senior faculty, Dr. Vijay More, you also sometimes might have seen the zirconia crown has some play. That means there is a space in the internal fit region. So this is the lateral view, and this is how the patient came, and this is how the final prosthesis was done. So you're very happy. This is another case, anterior 3 teeth fractured because of road traffic accident, a class 3 kind of situation. Implants were not possible in this case, or maybe the patient was not intended for implants, otherwise this case is for implants. Even though the ridge is not there, we do nowadays we have the tall tilt techniques and all, with which we do a lot of implantology. So a gingival porcelain is put, and a case is finished something like this, and reasonably good aesthetics. This is a very common thing which I do in my clinic, that is inlay. So whenever we have a class 2 situation where we can't do a good composite filling, sometimes despite using the best of matrix systems, there is a small gap which remains there. If the space between the cavitated tooth and normal tooth is more, then it is extremely difficult to get that proper contact. So we just make we just do a preparation. If you see the preparation, resistance form is so important, because whenever we do an intracoronal restoration, the inside buccal and lingual wall, the mesial or distal wall should be as parallel as possible. An inlay looks like this, which is cemented. The front is a crown. So this is a very, very common thing. Whenever the two cavities I see proximally, one will go for a composite restoration or a crown if it is for root canal, and other is going to go definitely for an inlay. So let's see this case. There are a lot of learning lessons when you start practicing. You treat like 10, 20 patients, 50 patients a day. Every patient teaches a lesson, and this also taught me a big lesson. So in 2009 I got him. He came with a complaint that he wants a zirconia crown because he met with an accident. 6 months, hospital stay because he had a lot of injuries. Now these two are hanging, the lateral incisor and the canine. Then what we did, we placed couple of implants in 2009 itself, and total loss of the alveolar bone, so we decided to go for a bridge. So the first contraindication for the bridge is if the canine and two posterior canines and two anteriors are missing. So this is against some, the rule of nature we were going. But you know what? So the lab guy says that, sir, Pontic 4 hai to chalega. Then you get that thing, So I didn't go to the literature, I just went ahead with a zirconia bridge. My lab did a beautiful job, gingival porcelain and all those things are cemented. Looks good. 15 days, catastrophic failure. 15 days, everything shattered, lakh of rupees he spent and everything is in vain. But in this case, because this is from 3M lava, at the time 2009, even we were not aware of the material science. Zirconia was booming. Patients like this, they do Google, they ask many people and come to you for the zirconia bridges, zirconia crowns. It's difficult to convince them for a metal ceramic or an implant. Of course, implant was very difficult because lot of loss of tissue. So what we did was we did a monolith bridge. Guess what? The monolith also broke. So we finally resorted to a metal ceramic, our old technology. 8 teeth since 2009, this bridge is there and it is still staying. Of course, long span bridges, we should use a non-rigid connectors and all, but I don't believe in non-rigid connectors. I just did a bridge and finished it off. And this is how he looks, and he is there since probably 15 years. Nowadays, zirconia is fracturing. Try to understand. Whenever the patient comes to the clinic, first thing a dentist wants them to do a zirconia crown, because there is a lot of money, because there is no headache, there is no high points, there is beautiful aesthetic, but there is a big problem associated with zirconia, which I am going to discuss today. This patient came to me. These crowns were done in Delhi, and this fractured. So 3 crowns connected zirconia crowns. Another biggest mistake people do, whenever we have 2 adjacent crowns, they have to be separate. Whenever we have such a long height, this is around 4 millimeters, so we don't require to join the crowns. So they join. There is a movement always going on in the tooth, because of the periodontal ligament, and that makes a lot of stress. That puts a lot of stresses on the cement and it fractures. So he had the other side also zirconia bridge, and I extract and place an implant. Look at this. Despite zirconia bridge, the teeth decayed. We have to understand there is some serious problem with this material, so we have to overcome by critical thinking, see what exactly is happening. So let's see some studies, couple of studies. Undergraduates may not understand much, but a systematic review done by Taylor clearly said that the zirconia crowns had significant more rate of ceramic chipping, loss of retention compared to a metal ceramic crowns. And a randomized control trial, which is supposed to be the topmost evidence-based practice, said that the zirconia crowns have a success of only 74% after 5 years, and metal ceramic, look at that, 90% after 5 years, done by Pasia. So let's explore why zirconia is failing. So I usually get metal ceramic crown, a leaky margins, and a zirconia crown which is fractured in my clinic. So I started thinking, what is happening with the zirconia crown? So let's see. This is a classic, preparation of zirconia crown which I do in my clinic. It all depends upon the internal fit. The zirconia crown fits very well at the margin, but it doesn't fit well on the internal side, that is internal surface. There is a definite reason for that. So the reason explained in the literature is, so our laboratories have 1 millimeter, 2 millimeter burrs which drill the block of zirconia to make a crown, isn't it? It's a CAD. It's a CAD procedure. So certain areas of the tooth preparation, you have a very pointed line angle or a pointed point angle. So what the burr does, a millimeter burr, it grinds away that point and makes it rounded inside. That's why this play we see in the zirconia crown. It's not only that, it makes the zirconia thin at that point of time, at that point of where there is over preparation. Many laboratories can afford 0.5 millimeter drill, which makes it exactly fitting, but that increases the cost a lot. So many of the laboratories don't invest so much and resort to 1 and 2 millimeter drill, which results in internal fit which is which is more. So when you program a crown, you put cement thickness as 30 microns, but at the end, after fabrication, somewhere you have 200 microns, somewhere you have 500 microns. That means 0.5 millimeters of cement thickness is there, and which will make that portion weak, because as the zirconia thickness reduces, the load bearing capacity also kept on reducing. This study by somebody in 2014 which has been done. So Burgess, this article is very crucial to understand the cements. So we have to have less than 25 microns of cement, which is very tough. But when you consider the glass ionomer, resin, self-adhesive resin, the resin portion is the cement which is giving highest compressive and the tensile strength. So whenever possible, use the resin cement. But as a rule, if the height of the tooth is less, only then use resin cement. Otherwise, GIC is enough. So a study by Kristen Mall said that for the cementation, crown rotation decreased significantly when the cement thickness increased from 15 microns to 50 microns. So as the crown thickness increases, so as the cement thickness increases, the resistance form decreases. So nowadays the same story is continuing with the metal ceramic crown, because nowadays nobody is doing hand wax pattern. They are all milling the wax pattern. Many laboratories, many dentists also don't know that the wax patterns are not done with the hand nowadays. They are done by the CAD, that is designed and casted. But the same principle applies, that the burr diameter is small, is big for such kind of milling. But a good laboratory use 3D printed resin pattern. 3D printed resin pattern is much better than a CAD resin pattern for casting. So then entered the other material, Emax. Emax is a very old concept, like 25-30 years of history we have. Let's see something about porcelain laminate veneers. Are the students following me? Yes. So they are not sleeping. Good. So let's see some history. You know who is Michael Buonocore? Finally, right? Yes. There will be some photo hanging in the college. So he is a guy who gave acid etching, and acid etching increased the surface area by 2000 folds. And he is a guy who gave composite resin. Virtually no clinic on this earth can run without acid etching and composite resin. So all the senior faculty can agree with this. So when we speak about porcelain veneers, they are wafer thin, they are very thin, like a 0.5 millimeter translucent shells. They are bonded to the front surface of the tooth to correct lot of dental issues, diastema or discoloration or malposition, etc. And Mauro Fredini, who is one of the best aesthetic dentistry right now in USA, did a study of 12-year-old retrospective study and showed that 98% success if the porcelain veneer is in enamel, and only 65% success when the porcelain veneer is put on the dentine. So it becomes very important that we don't grind much, we keep our preparation in enamel. So indications: discoloration, enamel defects, diastema, malpose teeth, aging, agenesis, etc. So mainly we concentrate on the type of preparation. We have incisal butt joint preparation, chamfer, and incisal lingual wrap preparation. A butt joint preparation is like this. We all have done amalgam fillings. Okay, we give a butt joint, right? So this is like a butt here and a chamfer finish line all over. The thickness of grinding is by 3-tier diamond burr, which is hardly 0.5 millimeters. Butt joint preparation is done for increasing the height of the tooth. Incisal chamfer preparation, where you give a chamfer even at the incisal edge, where you don't want to change the anterior guidance. And this is the most versatile preparation, that is incisal lingual wrap preparation, where you take the preparation a millimeter and a half on the palatal side. So he is Gordon Christensen. I am a big fan of Gordon Christensen and Schillingberg, because they are the one who actually enlightened this whole world about the fixed dental prosthesis. Whenever possible, about the shade selection, whenever possible, do it in daylight. If not in daylight, you use a color corrected light. So do not stare the the tooth for more than 5 seconds. Can anybody answer why? Interns are there? Yes, okay. So why shouldn't you stare? I mean, you have taken a shade, right? Shade selection you have done for ceramic crowns or for, for complete dentures. So you don't stare the shade tab for more than 5 seconds because it saturates your rods and cones. So they start interpreting a wrong shade. So whenever you do this, you are not able to select the shade, you look at the other plain background and come back to the patient. So it's always good to have a second opinion by your associate or a technician. Shade guide should be kept at an arm distance, and the stump shade has to be given, especially when you do a laminate veneer. Stump shade is nothing but shade after the tooth preparation. So let's see what is ceramic. How do we do ceramic bonding? So the strength or the force to remove the veneer from the tooth is comparable to the force to be removed, to separate dentine and enamel at the dentino-enamel junction. Meaning we can achieve almost near nature strength between the veneer and the tooth, but we just have to follow the protocol which has been put forth. So let's see how the bonding happens between the ceramic and the tooth. We have a hybrid layer, we have a resin cement. Hybrid layer is nothing but a shattered, after grinding pieces of enamel and dentine along with the resin, it forms a conglomerate which is called as hybrid layer. So before going in detail, let us understand the substrate. Enamel 88% mineral, dentine 50% mineral. So dentine has a lot of moisture. That is why when you have a preparation of veneer into the dentine, there is a failure because that moisture doesn't allow it to adhere, because resin cements are not water based. So this is how the enamel looks, and this is how enamel looks after grinding. So this is a thick layer of smear layer, and the same thing happens. This is an uncut dentine and smear layer on the dentine with a dentinal tubule. So after etching with orthophosphoric acid from 15 seconds, we get so much of microporosities onto the enamel. This holds good even for cavity preparation. This holds good for all the areas where you are using composite resin. And in the dentine, we have to etch only for 8 to 10 seconds. Anybody can tell why? Anybody from the audience? We are not supposed to etch the dentine for more than 10 seconds. Why? Lot of water. Lot of water will be there. Okay. Anybody else? Sorry? Dentinal tubules will collapse. Rather, not a dentinal tubule, because dentinal tubule is a long tube, So we are talking about 2 to 5 microns. So when I etch the dentine for 8 to 10 microns, only 2 to 5 microns of the mineral is gone, and all the collagen fibers stand like this, like a porcupine hair. So in that porcupine hair, that bonding agent and resin cement goes, or a composite goes, and establishes a bond. Whereas if you increase the etching time, like 20 seconds. So when you do a 20 seconds, this demineralization portion will from 5 microns, it is going to become like 10 microns or 20 microns, where the collagen fibers are not standing. Collagen fibers are all slip. So the bonding agent doesn't flow. So you get a poor bond. So whenever you do a composite filling, wherever it is, now I am talking about veneers, but it holds good for everywhere. So the resin goes into these standing collagen fibers and form a hybrid layer, nothing but a very strong bond. And this is how the resin flows into the dentinal tubule. So for the veneers, we have to do a veneer preparation also. So for veneer preparation, we use hydrofluoric acid. Hydrofluoric acid is a very caustic in nature. So we buffer it and then use. So this yellow gel is nothing but hydrofluoric acid, which comes in 2 percentages, 5 and 10, maybe 5 and 9.5 some companies. If you are using 5, you etch the veneer for 20 seconds, and if you are using 9% or 9.5%, you etch only for 10 seconds. Because it is too toxic, too caustic, it removes the lithium disilicate. So if you leave it for a minute, sometimes you find the veneer has become still thinner and it may crack. So these guidelines are very important to understand. Then you prime. We have 2 primers in most of the clinics: ceramic primer by 3M and Ivoclar Monobond S. So you keep on applying the primer for 60 seconds, allow it to dry on its own. So this is how lithium disilicate looks. So we have seen enamel, we have seen dentin, and we have seen the other side, the lithium disilicate. So much of, and this is a scanning electron microscope photograph. So much of depression will hold the bond and the resin cement so tightly that it is virtually inseparable. So let's see some cases: a fractured central incisor, both the central incisors, appreciate some diastema between all the teeth. So what is the treatment plan for this? It's a very simple case, it's a very simple case. You just go ahead with the root canal for this, a post and core to build, and don't do anything for this except for a veneer. This doesn't require a root canal and a crown. So look at the way it is fractured, it is fractured in a funny way, So do the preparation. This is how my tooth preparation looks after for the all ceramic crown, and this is how my veneer preparation looks. So as I told you, veneer should have a wing, veneer should have an incisal overlap on the lingual side, and there is a small bevel. Can you appreciate this bevel? Because it was fractured zone. So we strive to increase the surface area as much as possible, keep the enamel alive there. And whenever there is diastema, there is no, I don't give a wing, I just go into the palatal and leave it. So that's how the veneer preparation is done. So this is model, this is the two veneers, and this is how the patient looks. So pretty decent aesthetics, and this diastema were closed with the help of some composite touch-up, and this is the final restoration. So this is how she reported, and this is how she went, probably done like 5 years back, and everything is intact, So whenever we do such cases, we always keep a record, call them, because in India patients are not bothered. They don't come to the clinic to show, in implant cases also, full mouth implants, so many we do, they are not bothered to come because they are eating well. They will come when there is infection in the implant or something like that. But we do call the patient very often to check what is going on. This is a second case. So complaints of proclined anteriors, orthodontist will be Anand angry with me with this treatment plan. Where is Anand? Here. Oh, sorry. So what this first line of treatment is orthodontics. By default it's going to go for orthodontics, but many people come that they say, sir, next week shadi hai, Canada jana hai padhai karne ke liye. So many patients we get, so we have to resort to some prosthetic option, smile analysis, a thorough smile analysis. I'm not going to go into the principles of smile designing because it's going to become a very big topic. So 2 root canals and 2 crowns are done. 2 root canal crown and 2 veneers are done to improve the aesthetics, and this is how it is improved. And if you see the palatal aspect, we have taken the central incisors as behind as possible. So this is how the smile is changed. This is all Emax veneers. This is another case. Lot of composite restoration done here. And what is this? This is the most simplest way of closing the diastema. I call it as 1 minute diastema closure. So you might have seen many cases like this. It eats up the interdental papilla, it complicates the treatment plan. So you take some composite, you press it in between the teeth and cure it. Diastema closed, 1 minute, take money. But if you really want to strive, get that contact point good, make it plausible, you have to really work hard for probably 15 days because there is a soft tissue which is also involved. So in this case, a thorough smile analysis. We have a chart in our clinic which we use to analyze the smile. 4 veneers planned for this case. Look at the preparation. There is a wing, nearly a supragingival, because whenever possible I keep it equigingival or supragingival. I don't go below the gingiva whenever possible. So because this is a fine transition, we are using metal free ceramic. If at all it is seen in the patient's mouth like a gummy smile, that doesn't matter much. Again, here there is no wing. So whenever we have a diastema, you just chop off from the buccal to lingual. But the most important thing is these preparations are classically finished with a yellow band diamond burr. They are not rough because the veneer is so delicate that the rough surface can interfere with the seating. So make it smooth. And the cementing technology, it is a bonding technology, so we need not worry about increase in the surface area. So temporize, before veneer fabrication done. Can you see something here? The interdental papilla has gone high. Why? Because there is a mistake in the temporization. So see this, my temporary crown, after doing so much of preparation, next patient waiting, you made an impression. So you don't give so much of attention to such kind of small things, but you have to remove this extra piece of composite. But eventually this will be filled over a period of time. So this is the patient how we started, and this is how we ended. So this is a next case. So there are some 4 or 5 cases, and then we'll go for the implant. So this is an implant crown. This case was treated in Canada. I was thinking, wrong dentistry happens in India, but in Canada, US, UK, I get so many patients from there. Even there, the crowns and bridges done, root canal done are also pathetic. We need not worry much. We always think that West, these people do a lovely job, but that's not true. So this is an implant crown, a PTC implant, and according to the patient, she said that they have chopped the adjacent crowns to fix this, and now there is a purulent discharge from this. The crown is moving. We remove the crown. There is the gingival margin is not proper. It has gone high, obviously because of the infection related to implant. A thorough treatment plan. Crown was removed, and a veneer preparation was done for these two, and this metal crown was changed to a zirconia crown. So this is a zirconia abutment, and on this zirconia abutment we did the zirconia crown. These two are Emax crowns, and this is Dmax veneers, and this is a zirconia crown. Again same principle, 4% I have etched for 20 seconds, 9% I am going to etch for only 10 seconds. So apply ceramic primer, etching for adjacent teeth, bonding, and then cementation. So this is how the gingival contour was re-established. We did some little cautery for especially this central incisor to get the gingival line perfect. So we started here and we ended here. So one very important tip here is when you are cementing the veneers, you etch the tooth by 37% orthophosphoric acid. You do selective etching, meaning wherever you see enamel, you etch first, and then you etch the dentine. And dentine should not be etched for more than 10 seconds, I told you, and you just agitate till then, wash it. Apply the bonding agent, do not cure. After bonding agent, we are taught that the bonding agent has to be cured, and then a veneer has to be placed. But here when I was cementing the veneer, blow the air for the bonding agent, let it become too thin, let the solvent goes away. Then without curing the bonding agent, you you bond the veneer, because that bonding agent is going to increase the thickness. This is another case, a smile analysis. These two are root canal, veneer preparation, temporization. So these two are crowns. This is veneer we fabricated, and bonded. Okay. So this is how it looks in the after finishing the treatment, the smile and profile. So this is how we started, and this is how we ended. So the revolution in veneer happened in my life in 2012 when I met this guy. His name is Dr. Galib Gurel, who practices in Istanbul. He has come only once to India in Bombay, and we went to do his workshop, and he gave a technique called as aesthetic pre-evaluatory temporaries. So our intention is to be in enamel, and this technique is fit for getting ourselves in being in enamel. The thorough smile analysis, you can see a lot of hypocalcification spots, a broken tooth, diastema. A wax up is done, and you make the wax temporaries on the patient's mouth. You show the patient, you take an acceptance that this is, this much the veneers are going to come out, or the length of the veneer would be so, or crown would be so, whichever you are doing. A perfect lingual flap preparation was planned. So this is how the veneer I do. So these are the temporary crowns, they are not the tooth. So my intention is to go to a depth of 0.5 millimeters maximum. So on the temporary I start grinding, I mark it, then I do the incisal reduction, and slowly with the round and tapered burr, that is DR.12, which is my favorite, SO21, which is my favorite. So keep on removing the enamel in between. So when you start removing the enamel, you see that, so much of enamel is still left, you know. So you have complete control to keep your preparation in enamel. This is the final tooth preparation, 1 crown and rest 5 veneers. A spot etching is done to put this crown back, or a temporary back, because these are all working women, so they don't want to go out without the temporaries. So 1 crown and 5 veneers are fabricated, and this is how the veneers are bonded. So premolars were requiring a veneer, but maybe she will do it later. So this is how the smile improved from this to this. This is a final photograph. So another case, we keep on, nowadays this is only aesthetic pre-evaluatory technique, no freehand veneer preparation. So if you see carefully, there is diastema, there are a lot of decayed portions somebody tried to fill everywhere, so requiring aesthetic treatment. Make the temporary, same principle, start grinding into the temporary so that you have complete control on grinding, and this is how the preparation looks. The 4 veneers. So whenever diastema, I told you, I just chop it off, there is no wing. So here small wing, here also small wing, but on the laterals I didn't do any wing preparation. So 4 veneers etched with hydrofluoric acid, bonded. So this is how she reported, and this is how, look at the margin, look at the contact point, and incisal notch, gradation of the colors. So whenever somebody comes for the aesthetic treatment, you have to be bang on what the patient wants and how best that can be executed for long-term prognosis. So this is one case which is very close to my heart, and 6 veneers I had done in probably 2006, and 15 years still everything is intact. That means the bonding technology is very powerful. Only thing is you have to follow all the steps as discussed. So last portion of my lecture would be implant supported fixed prosthesis, and the digital aspect Dr. Priyam is going to go in detail, but I am going to go little conventional aspect. This is a very, very common thing which we get, a broken tooth after root canal, immediate extraction, place the bone graft, and this is how the implant is seen, in the arc of in the occlusion, and this is an implant crown. These are very, very common things which we do. This is tooth, and we place an implant and a crown. So slightly seeing the complex cases, this case anterior thumb plastic bridge wearing for very, very long time, removed completely rotten teeth with a draining sinus. So we planned for extraction, placed an immediate implant, did some grafting, put a temporary. It's very, very important to put a temporary immediately whenever it is anterior. This is a temporary crown done. This temporary is going to stabilize the tissue. So here can you see the interdental papilla? The interdental papilla is not lost only because we have done an immediate temporization. So this is how it looks after a few weeks of the cementation, and this is how it looks soon after the cementation. So this is how we started, and this is how we ended. So in the X-ray looks like this, fairly good. So another case, extraction immediate implants, nowadays we are doing in all the areas like lower posteriors, upper posteriors, there is no issue, and after clean extraction I prefer not to place in the center, I prefer to place slightly lingually the implant, so that it comes in the line of teeth, and a screw retained crown. Almost all crowns, implant crowns, are screw retained in my clinic, except for anteriors where I don't get a perfect angulation. So this is how the tooth was implanted, healing abutment put immediately, and this is after 3 months. Can you spot the crown? All a dentist, you should spot the crown. This is an implant supported crown. Can you just spot the crown? Final year interns, staff. I am so happy that the dentist also can't spot the crown. See, it's here. This is an implant supported crown. So we can get that architecture of the gingiva only when we do a temporary crown. You know, I just wanted to emphasize the significance or importance of temporary crowns. So this is a tooth, we extracted the tooth, did a palatal osteotomy, got a torque of like extensive torque like 50-60 newtons, made a temporary crown. Now this material is a clear silicone, you know, clear. The way we use impression material, similarly we have a clear silicone, we use that, and a temporary crown was done, and this is an X-ray after temporary crown, and this is how it is done. Case is finished after 3 months. So immaculate soft tissue stability if you go for a temporary crown immediately. This is another case which is close to my heart because this is my children. I have 2 children, and there he is the football coach for my children. You know, he lost his central incisor long back, maybe bachpan mein, and he came to me for some aesthetic correction because he wanted to get married. So we gave again the orthodontics, which was denied. So what we did was, smile analysis was done, a thorough treatment plan, and we did first wax pattern, diagnostic wax up, and we tried to see how much width problem is there, putty index, and we grinded little more here, though keeping the walls parallel, we grinded more to create the room for the missing tooth. Gingival retraction, deep shampoo finish line, and fabricated a 4-unit zirconia bridge. Emax can be done only for 3 units. More than 3 units is zirconia. Zirconia also cannot be done more than 4 units. You know, if it is more than 4 units, go for porcelain fused metal. Now this is how he looked, and it lasted for probably 8 years or 8.5 years, and he came like this after 8 years, you know, and he broke the bridge along with the roots when playing football. He was in Kerala, he is a Keralite, so he broke, and now there is no buccal plate also to rehabilitate. So we did some bone expansion, bone splitting, and lot of bone grafting, a membrane placement, and look at the soft tissue stability and look at the bone stability. Now a zirconia bridge again is made, so he is now, you know, rehabilitated. So from here, this lasted for 8 years, and just see that this bridge did not break. This zirconia bridge did not break because the Pontics were more, the retainers were more, and only one Pontic, it lasts very long. And finally he landed in 2 implants and a 4-unit bridge. So coming to my final aspect of my presentation, full mouth implant supported, these are the very common cases we get with the sinus dip. So whenever there is a sinus dip, a common dictum is to just go for direct sinus lift. I put for 5 implants in the upper jaw, I put 6 implants in the lower jaw, and added 3 more implants to finish the case. You know how much time it took? It took probably like 12 months or 14 months, because after sinus lift, direct sinus lift, we leave it for like 9 months, then place an implant, leave it for 4 months because the grafted bone is not very strong. But nowadays this is not used. You know, nowadays what I am doing is a pterygoid and sinus bypass implant, which will save my time, and I can finish the case in 3 months. So this is a case reported, sinus dipped both the sides, some broken teeth in the lower. We removed and we placed 8 implants, the multi-units in the upper, 8 implants and multi-units in the lower, and finished the prosthesis. This entire prosthesis is a screw retain prosthesis. I can dismantle the prosthesis within 5 minutes, you know. This is a CAD prosthesis which Dr. Priyam is going to speak. So important thing is to have posterior disclusion even for the implant supported fixed prosthesis. So this is how he came and this is how he went. So this is how it looks. You know, you can see this is a pterygoid implant and this is also pterygoid implant. This is a sinus bypass implant like we do in All-on 4 and finish this case. Then we started exploring how can we rehabilitate if the tooth is there. If the tooth is not there, I can place a pterygoid. If the tooth is there, I can't extract a tooth and place a pterygoid. So we started doing trans-sinus implants with the use of digital protocol. So here if you see the X-ray, there are hardly a couple of millimeters of bone, which you can't do an implant here. So this goes for extraction, fracture, this also will go for extraction. So we did a surgical guide, you know. We did a surgical guide, and this implant is put from the buccal into the sinus and went and hit the lateral wall of the nose. So this is around 24 millimeter implant. Now this is how it looks in the X-ray. So this is immediate post-op, and after 3 months, beautiful integration. There is absolutely no problem because it is bicortical. You are engaging the first cortical plate here, and second cortical plate is the nasal floor. So this is how he looks soon after the cementation, and this is how he looks after 3 years of cementation. Some recession of the gum. This is multi-unit. This is not the implant, and this is 3 years follow-up. That means even though you push the implant into the sinus and engage the cortical plate somewhere, the prognosis is very good, and we are closely keeping an eye on this. So similar principles we are doing in full mouth rehabilitation. The digital protocol will be discussed by Priyam. I am not going to go in detail. So sinus dip, no bone even in the pterygoid, nerve is so high like 4-5 millimeters. We made a surgical guide, and flaplessly we place implants like this. This is called a stall till protocol given by Dr. Venkat Ratnanak. He is one of my best friends. I learned this technique where we put 2 pterygoid implants to sinus bypass, and this nerve is bypassed. You feel that it is in the nerve, but it is not in the nerve. It is bypass, placing the implant from lingual to the buccal. So that gets me to end of this presentation. I thank Katara Dental for their constant support. Almost all my job is done by Katara Dental, and these are my references. So thank you so much for patient hearing. Just check this out. One second. Bas, ठीक. All good. One second. All right, a very good afternoon to all of you. I think you've been sitting for a very long time, so, and I would like to know my audience. So, do we have second year over here? Second years? No second years. Third years? No third years? Just stand on your place, please, so I can see where you are sitting. Third years, please stand up on your place. Stand, stand, stand. Third years. Okay. And fourth years? Sit, please. Thank you. Please stand. I know you guys are very nicely color coordinated, but I'm not able to make out who's who. Thank you. Interns? So everybody in red is interns. Thank you. All right. So in the first part of our talk, Dr. DIXIT has already very nicely spoken about the basics of prosthodontics. I'm here to take things a little bit forward from him to see what the future trends are. Now, why it is important for you at this age is because at this age, you have just started dreaming into dentistry. You're looking at possibilities, and that is what I am here for. The only way you can predict the future if you build the future. Okay, and to build a future, you need tools. So today we are going to talk about all the tools that are there currently present for everybody. And we are going to talk, is there a problem? Okay, and we are going to talk about 3 basic tools which are becoming very prevalent in the current market. And I hope and I pray that you all get a hands on that and you all get to use that in your practice very soon. So with these tools, we are building the future of dentistry, and you are the future of dentistry. So you have to know about these tools, and you have to get well versed with these tools. The idea of talking to you all today is not to impart any knowledge. I am not here to teach you. I'm here to just show you a glimpse so that a curiosity in you takes over and the imagination is going to take you far ahead. Many thanks to all of you, first of all, to Dean Sir, to Shigley Madam for calling me here, giving me an opportunity to talk to all of you, and the wonderful staff organizing everything with the interns over here. I also thank my very own Indian Prosthodontic Society, Pune branch. We are focused on prosthodontics. We do a lot of work in the field of prosthodontics, which is focused on the postgraduate students and the clinicians in the city. And I hope if few of you take up prosthodontics in future, you'll also become a part of it. I also thank the biggest organization, one of the biggest organizations in India, the IDA and the Pune East branch for becoming a part of it and giving me this opportunity. Coming back to what we are here for. We all have evolved. We all have started from basics. There were times when we were sitting where you are sitting in our own colleges, and we were looking at somebody doing something miraculous. And because we were exposed to all those things at that point of our life, we are here and we are trying to go forward. And that is what all I hope for you all also. And whatever pictures you see here today are all done and clicked in the clinic, my own clinic. Whatever you see, these are captured by us. Why I'm telling you this is because at this stage itself, you all have got wonderful phones in your hands. Please start recording whatever you do. A small impression, a small tooth preparation, a small composite filling, please record everything that you do. If you don't record, it does not carry any value. And when you record something that you do, this is the case that I just put in. I could not put the full case because this is the case which I finished on this Saturday. But when I look at this picture and I sit with this picture, and that will help me improve, and the same thing I want for you guys. So don't wait for big cameras, big equipments to land in your hand. You have a very powerful phone in your hand. Get into a habit of recording everything. Start clicking everything apart from selfies. All right, so as I said, let's see what and how it is done in my practice. And I'll simply go case by. I will not go into theory. I'll simply go by case by, and if at all you don't understand anything, if at all there is some word that I'm uttering and you don't know, please raise your hand.
This is an interactive session. We are here to interact. We are here to discuss things and grow. So don't feel shy. So the first case is a case of ovate pontics. Now pontics is something that you all have read in 4th year, 3rd year, and you're doing it as an interns. So there are different kinds of pontics, and each pontic has its own merits. Each pontic has its limitations, and certain situations demand certain kind of pontics. This is a very particular case, and the ovate pontic is something that is not very commonly used in our practices, at least in my practice. But I got an opportunity and I decided to show it to you guys also. Coming to a basic knowledge about ovate pontics. Ovate pontics are generally used in anterior or posterior teeth where you have a high smile line. So it is used when you want aesthetics. The biggest problem with 3-unit bridges or 4-unit bridges is that when you see the patient, you can see that the tooth is sitting over the ridge, right? Why? Because you're using a modified ridge lap pontic. Modified ridge lap pontic is supposed to sit over the ridge. So that's why the aesthetic is compromised over there. Then, in anterior cases, patients cannot afford an implant. If the patient cannot afford the implant, that means he cannot be denied the right of aesthetics. So these are the things when come up in the picture when you cannot do an implant and give some fabulous wow aesthetics, and you manage something conventional which is time tested, has worked well, and will work well. The contraindications, the cases in which you cannot use is when you have a very thin knife edge ridges. You cannot use ovate pontics. As I said, it is used when the aesthetics is needed, so of course the aesthetics in this case is very high. Hygiene is sometimes a problem because if the patient is not able to floss below the pontic, then hygiene is an issue. So that is one disadvantage or one limitation of using ovate pontic. Plus, it takes time to develop. You have to modify the tissues, you have to manage the soft tissues to get what you want. So it takes time. Sometimes you may require some kind of surgical intervention to develop what you want to develop. I know it's difficult for you to think, but let's go by the case. So this is the case. This lady is 62 years of age. She was playing with her granddaughter. The granddaughter bumped her head into the central incisor, and she had pain, and she came to the clinic saying that something is hurting and I feel that the tooth is moving. When we checked the patient, the segment was mobile and it got simply separated. Female at an age of 62 is still very demanding for aesthetics. It's important for them. So what is to be done? When I cleaned up, we waited for the bleeding to stop. You can see what was the situation. She was in severe pain. So for an immediate pain management, we just extirpated the pulp. Okay? And next question is, how will she go home? Can she go home like this? Would you like to go home like this? I would not like to go home like this. But it is something which has come as an emergency to your clinic. You are not prepared for it. Your lab is going to take time to make a crown and bridge for her. So what we do for her is use a denture tooth. The very denture tooth that you all have been using in your complete denture. We take a central incisor of a matching shape. We thin down the central incisor and we use a fiber. You must have read this term fiber reinforced bridges, right? Have you? Yes? All right. So this is a kind of fiber reinforced bridge where we bond this acrylic tooth to the fiber from the back. We make sure that there is a proper gap for hygiene, very, very critical. As a prosthodontist, I'm very scared of pink. I have nightmares if something goes wrong in pink. So I make sure that there is proper gap for oral hygiene maintenance. Patient can use an interdental brush, patient can use a water flosser, and they can keep this clean. And another very important thing is that do not give any eccentric contacts on that pontic. You don't want that tooth to debond, you want that to be in the mouth. Now by doing this, I've done few things for the patient. First of all, it has calmed the patient. She came with an emergency, she has lost a tooth, but nobody is going to know. That is a big thing for a patient. Second thing, she came with a lot of pain. A small management will make sure that she's comfortable when she goes back. And third, very important thing, this gives the patient the time to think what she wants. Does she want an implant? Does she want a bridge? Can you do something like a post and core? Is it possible? Is it to do something like that? It gives the patient the time to think, make a decision, and then they can come back and you can do a much better work because now you are also prepared for the situation. It's not an emergency for you anymore. So she comes back after approximately 15-20 days, 2-3 weeks, and she says, I cannot afford an implant. I want a bridge. Now, normally what you will tell the patient, you extract the tooth in oral surgery department, you tell the patient, 1-1.5 महीने बाद prostho department चले जाना, RPD bridge कुछ हो जाएगा, right? So you ask the patient to wait for 1-1.5 months without a tooth so that everything can heal and then you can give a prosthesis on top of it. But again, things are different over here. Things are different in my practice. So what we do is, we follow the basics of tooth preparation. What you're seeing on your screen is what you're expected to do and what you see in your books. Sir has already covered basics for you. He has a different preferences for burrs. I have a slightly different preference for the burr. So if you look at the picture, I have made an indentation. I've created a depth groove. I have been doing this for a long time now, and I still make depth groove because it is all about delivering a good result every single time. You have to be precise. You have to make sure that you're following the guidelines properly. 0.5 millimeter here and there is not okay with us because we are dentists. We are dealing with that 0.5 millimeter and 1 millimeter. So if you see this central depth groove, can you see the end of the burr? And can you see the end is 290-degree angles and a flat plane? So this burr is a straight fissure burr because I want to create a shoulder margin. Can you understand now how we get the shoulder margin? Because we are using a burr which is flat at the end, which is going to give us the shoulder margin. Now the depth or the thickness of the burr is also very important. If you read your Schellenbergs and you read your Rosensteels, they will say 1.5 millimeters. Can you measure 1.5 millimeters with your eyes? I cannot. I have 4. I cannot measure 1.5 millimeters with my eyes, but I can certainly measure it with my burrs. So whatever burr when you buy and when your staff tells you, okay, buy SF11, SF12, SF13, 14, that means something. That 1, 2, SF11, SF12, SF13 means the diameter of the burr. So the things that you read in your dental sciences in the first year, which you found very boring, the rake angle, remember? First years? I think in my times it was in first year, maybe it's for you in second year or something. All that is very important in clinics. When you start working, you realize dental materials is a very, very important branch in your clinics. So we use a burr to mark the depths. This is marked at 1.2 because I'll be finishing it up where I'll be using another 0.3, so I'll end up with 1.5 millimeters. Then we go to the proximal areas. Can you see I'm trying to create an enamel lip over here? Remember the basic chapter of tooth preparations where you have to preserve the neighboring teeth. You should not nick the neighboring teeth. You should not nick the next tissue. That is one of the ways. You can create an enamel lip and then you can just cut through without damaging your neighboring teeth. This is nothing hi-fi. This is the basics that is there in your book that you are reading and I hope not mugging for your exams. Understand what you are reading and you have fabulous results in your practice from day one. So what we do, we finish the tooth preparation. Please remember the tooth is still inside. The fractured tooth is still inside and we extract the tooth. So we have finished the preparation of the tooth. We have prepared the teeth even before extraction. Then we extract the tooth. This is the extracted root piece. And we have a wax up which is ready. Wax up or mock up is where you use wax or acrylic tooth, like how you do your teeth arrangement. Same way, do your teeth arrangement for fixed prosthodontics and you have that as a guideline or as a mock up. With that mock up, we make a provisional. Okay? Temporary is a very common word which is used, but preferably don't use temporary in front of your patients. It does not look very nice. It feels that you're giving something which is substandard. Provisionals in no way are substandards. They have to be as good as your final prosthesis, and that is what we are trying to do. So we create, and can you see this part? Can you appreciate this part? So what we have done is we have made sure that some acrylic flows into the socket so that we can create a good emergence profile. That is what overweight Pontic is all about. So that's on day 1, immediately after extraction. You can see some blood over there. And this is over a period of time. So what you have to do is you have to recall your patients every week. If the tissues are not working the way you want, you can add some composite, you can add some acrylic, and you can change the way the tissue is behaving. That means you can push the tissue, you can make the tissue grow in some area. It's a fabulous thing to do, and the results are amazing. Problem with this patient was that she didn't keep the hygiene as good as I would have liked. See, as I said, I'm very scared of pink. Anything that the pink doesn't like, I don't like. But unfortunately, she didn't keep the hygiene very good, and there was food particles. Anyways, we can't wait anymore because it's not going to give us anything after 8 weeks. This is how the tissues are after 8 weeks. Can you see the scalloping which has happened? Now when you go back to your clinics and you see a patient whose extraction was done, see his ridge. His ridge will be flat, okay? But just because you managed an emergency, and you planned something very well, you could develop this. This is nothing extraordinary. This is what you have in your books. You just need to follow it. We make a conventional impression. You can appreciate the shoulder margin over here, and you can see the difference in the shoulder and the chamfer, the thickness. What sir has already mentioned. You can see the thickness difference over there. You have to you have to follow the principles of tooth preparation. I'm not going to go into depth of where the margins end and how you start everything. And that's the prosthesis. Again, it's a basic porcelain fused to metal prosthesis. Nothing big about it, but the execution is by the book, and hence the results are good. You can see there is metal inside, and what you can see is that we have kept a lingual metal collar. Can you see that? We have kept a lingual metal collar, whereas in the buccal surface, in the labial surface, we cannot have a metal collar because it's an aesthetic zone, right? So there is something called as shoulder porcelain. Have you heard this term? Shoulder porcelain? Please note it down. Write it in your phones. Shoulder porcelain. Use this whenever you are doing a case with high-end aesthetics. You can add shoulder porcelain in the labial areas, and you can get very good aesthetics in PFMs also. That's the post-op. And please remember, this is taken by a very good camera, and you're seeing it on a huge screen. Okay, in a patient's mouth, you cannot tell. Trust me, you cannot tell. And can you see the stipplings on the gingiva? Can you see that? This is a recall visit. If you see stipplings on the gingiva, if you see the gingiva healthy, that means your prosthesis is in harmony with your pink. Again, I'm very scared of pink. I want my pink to be good. That's why it is very important that your prosthesis should be fitting well and should be cleansable. Okay? That is a problem in overweight Pontics, but luckily in this case, after repeated instructions, the patient was following it. That's the post-op. So this is a simple case of overweight Pontic done as by the book, and the results are acceptable. But we are talking about technology. We are talking about future. So let's start introducing technologies one by one. So the first technology that I'm going to talk to you all about today is dental designing and planning softwares. This is the first technology that I'm going to introduce to you because this is the first technology that you will come across when you walk out of the college into your clinics. Going back to your first to final year and internship, you learn to make a tray. It's a nightmare to learn to make a tray. कभी मोटी हो जाती है, कभी पतली हो जाती है, कभी टूट जाती है, कभी चेक करने वाला तोड़ देता है. Happens, right? Happens to all of us, right? Then coming to the rims, wax rims. तो 1 मिलीमीटर के पीछे कितने दिन बिताएं, we all know, right? कभी 22 मिलीमीटर चाहिए तो 23 हो जाएगा, 23 नहीं हुआ तो 21 हो जाएगा. बहुत देर घिसने के बाद पता चला 19 मिलीमीटर हो गया. अब क्या करेंगे? right? So that my nightmare continues, and when finally you achieve that 22 millimeters, then there are bubbles inside, right? We all have seen that, na? सर लोग कर रहे हैं मस्त एकदम डार्क रेड शाइनिंग एवरीथिंग, हमारे वाली पता नहीं कहाँ से गुलाबी गुलाबी निकलती है, राइट? बिकॉज देयर इज लॉट ऑफ एयर बबल्स इनसाइड, राइट? सो दैट्स अ प्रॉब्लम. एंड टीम अरेंजमेंट 3-4 साल करने के बाद भी नहीं आता. आई एम टेलिंग यू ऑनेस्टली, आई हैव टॉट फॉर 2 years, नहीं आता. Okay, because you are not focusing on the basics. It's all a nightmare for you. I understand that. And then after that, you give a denture, you are not happy, and you're trying to convince the patient that be happy, it's a very good denture. Right? We all have done that. We all have said, kuch din pehno retention aa jayega. Right? We all have said that. So you are not happy, you are irritated, you're frustrated, you're angry, and in the end, you're sad. But imagine if I can take all of that away from you. Imagine that if you just make an impression and everything happens without any problems. There comes the planning and the designing softwares. The CAD is computer aided designing. So this is the designing softwares. These are not the only softwares in the world. These are the leading softwares in the world. Hence I'm telling you the name, so that when you come across, you know that there is something like that, and what is the purpose of that. So ExoCAD is one of the most commonly used designing software. ExoPlan is the most commonly used planning software. Dental Wings is again a software which can help in planning and even designing. And then there is 3Shapes. 3Shapes is a big company. 3Shapes comes with their scanners, their softwares, there's everything. They've just bundled everything together. And they've recently come with something called as 3Shapes United, where they have tried to bring all the companies on one platform, and they're just trying to provide things to everybody. Do note these things. Go to website, go to Google. After you have checked your Facebook, check these out. So you can do 3-unit bridges. Remember, you make an impression. Even if you make an impression, you don't need to pour it. You can just scan the impression. And then you can just do everything. So वो जो हम लोग बैठ के प्लास्टर घुमाते हैं, कभी पतला, कभी मोटा, कभी पतला, इतने में सेट हो गया. उसके बाद दोबारा शुरू करते हैं. And then the impression breaks, the cast breaks while taking out. All that is not needed. You can just scan it. Just scan it. And if you want the cast, just print it. Exactly like how you print your Word document in your home, you can print a model in your clinic. I do it every single day in my clinic. I don't even print models, I also print maxillas and mandibles in my clinic. Okay, so it's so easy. You can do cast partials. You have read it, I'm sure you have not done it till now. But you can design your cast partials, you can fabricate your cast partials with designing softwares. You can do implant prosthesis, because implant is a big thing. You can do your implant prosthesis, 1 implant, 2 implants, multiple implants, you can do everything. And the best part is you can do your dentures completely digital. Completely digital. If you have a powerful scanner, you can just scan the jaws. There are ways to take the JR and just do everything dental on the software, designing software. Just print, we call it as a monoblock trial. Just print the trial. Trial is, imagine your full denture, but just in one color. You put the trial in the patient's mouth, patient is happy with it, finalize it, done. You can do this in a day without hassles. And the teeth arrangement, you can see in front of you, takes 10, maximum 15 minutes. It's just click, 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 that's it. That's it. No burning of your hands with your wax knife. All right. That is where the future is. That is what is happening. The dentures are to evolve. We still have to go just a little bit more to do what I'm saying. But what I'm asking you to do is to dream that this is possible, this is happening. All right, coming back to cases. Single zirconia crowns. Now this is something that you must be seeing a lot on Facebook when you join different groups. Everybody is posting about zirconia, zirconia, zirconia. So let's talk about zirconia crowns. By the way, there's a lot of misconception on zirconia being called as metal-free ceramic, metal-free. Zirconia itself comes in the periodic table. If you can see it, sitting right beneath titanium, right? It comes as a metal, but that metal is zirconium, not zirconia. Zirconia is a ceramic, which is an oxide, and you have got yttrium, which is also sitting in next to zirconia. You can see that. it is stabilized with that. So it is not a metal-free ceramic, but it is definitely a ceramic on it. Some people differ on that, but this is my opinion, because I will follow what the basics is. The basics says it sits in a metal housing, in a metal zone in a periodic table. I will call it as a metal. All right, coming back to the case. Simple case, you must have read all this in your oral pathology and all that. You have got peg lateral, you have got microdontia, right? So it's a case which has got a microdontia. The guy is a young guy. He's about to leave Pune, go for a job somewhere else, and going to get married very soon. So his demand is that he only wants this to be done, and he wants it to look matching. So what we do is, we first of all document everything. Please remember, document everything. You need to communicate with your lab. You are seeing the patient, but your lab has never seen the patient. The only way they can see the patient is by documentation. So we document everything, and we take the shade even before we touch the tooth. Okay? We take the shade even before we touch the tooth, and we send it back to the lab. And one more thing, if you can all observe, there is something in the corner which is gray in color. Okay? That is something which has not come by accident. It is called as gray card. Note it down, gray card. Okay? It is gray card. You need gray card if you want to tell the color to your lab. Why? Because imagine you have got iPhone 13, you took a beautiful picture, and I have got some very basic second, third grade phone or quality phone. The screens are not going to be same. Your red and my red will not be the same. And then when I take it on my computer screen, your red, my red, and the computer screen red is not going to be same. So there has to be a way to standardize everything. There has to be a way where your yellow, my yellow, and the lab's yellow is same. And the only way you can do that is if you use gray cards. Okay? I'm not going to go in details. Read about it. If I ever get time again with you, I'll explain you how it works. So we did a wax up, first of all, and we did a very little preparation. I just wanted the margins to be defined. That's all. This picture shows you that even though I have not prepared anything in this area, there is still a lot of space available for the ceramic to come, because it's a case of microdontia. The size of the tooth is small. Just because you have a burr and you have a tooth in front of you, you are not going to trim it off and make it parallel from all the sides. You have to have a wax up, as sir was mentioning you. Santosh sir was mentioning you, when you are doing veneers, you do a mock-up and then you prep through that. It's the same concept. It's the same concept. And then we go back to our designing software. This is ExoCAD. The lab that I'm using is from Kolhapur. And we sit and we design and we talk. And can you see, we can see the contact also? How the tooth is going to contact? So it is not only about the shape or the size. You can see that the indentation over there. Can you? That's because there's a tooth contacting over there. And the articulators that you use, you must have read semi-adjustable articulators. Have you? Yes? Yes or no? Yes. So semi-adjustable articulators are already programmed in this software. On a click of button, the jaws will start to move as per the articulator values, and you will get a prosthesis which is as per the patient. So trimming outside is not needed because you have used a virtual articulator. The word is virtual articulator. Okay? It's very interesting. Search it. It's very good. Moving on. So the crowns come back and we fit it in. Can you see we have matched the shape? Can you see that small nick, small ditch is there? That's because we have copied from one side to the other side. You can copy the shape from one side to the other side. Sometimes it happens that patient had some accident as a kid or something, chipped the lateral incisor, chipped something, and when you're doing the crown, he says, I want the same thing. I want the same thing. So the only way you can give the same thing back is if you document, you have a pre-op records, you can transfer those records, and the lab can just duplicate which was already there. It's beautiful. All right. Since we are planning prosthesis, we can also plan implants. Okay. I recently have started doing all my cases through implant planning softwares. I've been using implant planning software for almost 6-7 years now, and now my practice only does guided implants. Okay. Of course, there are cases where it cannot work, we don't do that, but most of the cases do fall in this, and we are following that. So whatever you plan, I'm going to show this case in a little bit detail to you later on, but whatever you plan, so this image is not an OPG, this is an image taken from the planning software. So I have spent time and I have put this implant in this position, and that is how I want my implant in my patient. And you all at least go and visit him once and see how it works, okay? And later on, maybe you can read more about it on YouTube. So today we have this scanner with us for you to show. What are the advantages of using an intraoral scanner? The first advantage is that you can capture the area that you want to treat with an intraoral scanner, and not necessarily in one appointment. If you make an impression, you have to make that impression in one shot, right? You have to make that impression in one shot. But if you're using